We just got a message from Madam that she'll be joining shortly. So meanwhile, we can start our clinic. So a very good afternoon and a very warm welcome to the NITRD CTD NTF Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to extend a heartfelt welcome to our esteemed DDG ma'am, who will be joining us shortly, the directors and teams from NIRT and NTI, state TB officers, directors of STDCs, faculty members from medical colleges, district TB officers, medical officers, and all the other distinguished participants. A very warm welcome to our clinic. I am Dr. Neeta Singla. I am the Nodal Officer of DRTB Center at the NITRD. It is an honor to introduce the faculty from NITRD. On my right is Dr. Rupak Singla, who is consultant in the Department of TB and Respiratory Diseases. On my left is Dr. Saroj Meena. She is the senior pulmonologist at NITRD. It is now my pleasure to welcome our director, Dr. Upasana Agrawal. Dr. Upasana Agrawal has a very vast experience in TB and internal medicine, and she herself has been running a very successful TB HIV eco clinic. I kindly request Dr. Upasana to deliver her talk.
Good afternoon, everyone. And it's such an honor to be welcoming such a big community of TB physicians and other ID physicians, pulmonologists, internal medicine physicians. And I am really happy with the Trivandrum team because they have brought in such an important aspect of recalcitrant MOTT, which is something that we rarely discuss in the TB program, but which is a very important aspect of managing TB, that we also have to manage mycobacteria other than TB. And the fact that they are recurrent, they are difficult to manage is actually one of their many challenges. And I think Dr. Singla and Dr. Rajendra Prasad are one of the biggest experts in the field. And I also welcome the DRTB Nodal Office of Trivandrum. And I hand over the mic to Dr. Neeta with the hope and wishes for a great session.
Thank you, Dr. Upasana. So today, as a part of state-wise case discussion, we are focusing on state of Kerala today. So case presentation is by Dr. Sri Lakshmi. She is the Junior Resident Department of Respiratory Medicine at GMC Trivandrum. The state expert is Dr. Deenu Gaggan. He is the Assistant Professor at GMC Trivandrum, and he is also the Nodal Officer for the DRTB Center. We are also joined by Dr. Sanjeev from Kerala team, and the national expert for the day is Dr. Rajendra Prasad, who is the Vice Chair of NTF, and he is also the Director Medical Education at ERA's Lucknow Medical College. The clinic expert will be Dr. Rupak Singla, who is the consultant in Department of TB and Respiratory Diseases. So over to Dr. Sri Lakshmi for her presentation. Okay, so if Trivandrum team is having some technical issue, can we project the slides from here?
Madam, I will project from here, madam.
Okay.
Current version has to be unshared from your side. Madam, first it has to be unshared from your side so that I can show.
Dr. Sanjeev, you can try sharing now.
Yeah, I'll share. Sri Lakshmi, Dinu, have you been able to log in? Can you?
Yes, sir. I have some problem for sharing the screen.
Yeah, okay. So we have shared. You can just tell me and say next and I'll go further.
Okay, sir.
You can start.
First of all, sorry for all the inconvenience. I'm Dr. Sri Lakshmi, Junior Resident, Government College Trivandrum. Respected seniors, greetings from Nodal DRTB Center Trivandrum. Sir. I'm presenting a case of 55-year-old female hailing from Pandalam, Pathanamthitta district. She's working as a receptionist in a dental clinic, not working since 3 years. Presenting complaint, cough with mucopurulent expectoration on and off since 4 years, progressive dyspnea on exertion since 4 years. History of presenting complaint, history of episodic breathlessness and atopy to dust and smell since 2 years. History of dyspnea on exertion, grade 1 MMRC for 1 year, gradually progressed to grade 2 MMRC for 2 years and grade 3 MMRC for 1 year. History of irregular use of MDA levosalbutamol since 2 years. History of ATT intake twice in 2022 and 2023. Patient had been on diltiazem, metoprolol, ivabradine in view of sinus tachycardia and under cardiology follow-up now. Patient was initially evaluated at DT3C Pathanamthitta as a case of presumptive TB. She was evaluated with chest X-ray, shows right lower zone consolidation and sputum smear was negative. CT chest done during that time shows cavitatory lesion with consolidation in right lower lobe with surrounding ground glass opacity. Sputum CBNAT was MTB not detected. FOB done on MCH Alapura shows bronchial brushing AFB smear positive 1+. FOB was CBNAT, MTB not detected. ATT was started for the patient since 26 November 2021 for a period of 6 months. CCT chest taken at the end of the IP phase, new areas of involvement in posterior and medial basal segment of right lower lobe. At the end of the treatment, sputum FB was negative and hence declared cure. Patient again developed cough with mucopurulent expectoration and increased dyspnea on exertion. Hence, FOB was done again in July 2022, but did not yield any positive results. Due to persistent symptoms, sputum AFB was sent. 2 samples sent on 20 March 2023 and 27 March 2023 were positive 1+. Sputum TrueNAT at the same time, NTB not detected. ATT, that is drug-sensitive regimen, was started for the patient on 22 March 2023 for a period of 6 months. At the end of the treatment, sputum AFB was positive 1+. CT chest shows fibrosis with traction bronchiectasis in right upper lobe, middle lobe, lower lobe, and also apical posterior segment of left upper lobe. FOB was done again on 26 October 2023 and sample was sent for culture to IRL. IRL culture results isolated NTM, sent for speciation to NIRT Chennai, and LPA showed NTM intracellulare. DST was not done. Patient was started on rifampicin, ethambutol, azithromycin regimen from February 14, 2024. Follow-up sputum smear were positive, but cultures were negative. After 12 months of treatment, smear, NAT, and culture done at IRL. Sputum AFB was positive. AFB culture reported as culture yields AFB probably NTF. Sputum CBNAT, MTM not detected. The treatment was continued till 22nd June 2025 as we are waiting for the further results. Speciation and drug sensitivity test done at IRL Trivandrum shows Mycobacterium intracellulare identified. NTM LPA show resistance in RRL gene, that is macrolide, and resistance was not found in aminoglycoside. Patient was then referred to Nodal DRTB Center, Trivandrum. This was a result of IRL showing NTM intracellulare, and there were resistance in RRL gene, that is, it is resistant to macrolides. There was no resistance to aminoglycosides. And these were the series of investigations done so far and was created from our IRL department. I have already discussed these before. So the routine blood investigations were all within normal limits. Then serial chest X-ray. The serial chest X-ray, initially the chest X-ray shows right mid-zone, lower zone consolidation with some features of volume loss. Further chest X-rays done in 2023 shows more features of volume loss, and in 2024 further more lobes are involved, and in 2025 we can see the right complete involvement of right lung and along with new findings in the left upper lobe also. The CT chests were also done, and initial CT taken in 2021 shows lower lobe consolidation. Later shows further involvement of all lobes with more volume loss features, cavitation, bronchiectasis, and all. And at last, we were taken in, the CT chest were taken in May 2024. It shows right entire lung cavitation with fibrosis and bronchiectasis. And also, we can see new involvement in left upper lobe also. After nodal DRTB committee decision, decided to start it on a regimen with rifampicin, ethambutol, amikacin, clofamicin, and moxifloxacin. And the regimen was started on September 3, 2025, after obtaining clearance by consultations with cardiology, nephrology, ENT, opthal, CTVS. But patient developed a severe gastritis following the intake of moxifloxacin. Hence, moxifloxacin is kept on a temporary hold. Thank you.
Thank you, Dr. Sri Lakshmi. Are there any questions on the history? Would you like to summarize the case, Dr.
To summarize the case is about a middle-aged female who has been treated multiple times for tuberculosis on the basis of sputum smear positivity and radiological basis. And every time she was, at the end of the treatment, she was positive. Till in October 2023, patient was diagnosed as a case of NTM, and patient was started on 3 drug regimens since February 2024, rifampicin, ethambutol, and azithromycin. Both followed with smear and culture after 12 months of treatment for NTM came out to be positive. And so the DST was done, which shows resistance to macrolide. So basically, patient may be resistant from the beginning, and she was only getting to sensitive drugs like rifampicin, ethambutol, azithromycin. So now, after discussion with the DRTB team, the team has started her on injectables, and which composed of rifampicin, ethambutol, amikacin, clofazimine, and moxifloxacin has been withheld due to gastritis complaint. Questions are.
So,
may I come in?
yes, sir. Please.
Thank you for a very good presentation, I must say, but one or two things are not clear to me. As I heard the history, to begin with, she is about 55-year-old lady working in dental clinic. Since how many years she worked in dental clinic? Can I be sure?
Sir, for 20 years, around 20 years, she
for
was
20
working.
years. So for a long time, she worked in
yes, sir. But since 3 years, she's not working.
Right. And then the second point, she started with the breathlessness.
Yes.
And as I could gather from the history, she was off and on put on leosalbutamol.
Yes,
so,
sir.
Is there any idea that what was the basic, because she is suffering from many comorbidities, but I hear she has some heart problem also. So what was in the chest to begin with? Because breathlessness is 55-year-old lady. So what was the, initial impression? Because, to begin with, to have a breathlessness in pulmonary TB or in NTM disease, only thing is it's little difficult. So she has some background disease, background lung disease. Could it be COPD? What is about the, has she any history of smoking?
No,
any
sir,
history
no.
of tobacco use?
No.
Any history of exposure to biomass fuel or any other thing? But that was not clear from the history to me.
Sir, firewood smoke exposure present, but not that much significance, sir. She has an episodic breathlessness and atopy for 2 years.
So
but for that only she's taking.
She was known case of, in such type of breathlessness, only 2 diagnoses can exist. Either he is a known case of bronchial asthma, or she is a case of COPD, but history is not favoring that. So that because when I see the X-ray, in X-ray from the distance, what I see that there's an overinflated chest also there. So is she suffering from chronic asthma or COPD, something like that from history?
She was taking MDA salbutamol since 2 years, but there was no much relief in breathlessness after taking this inhaler. So The
No, I
asthma was
wonder-
not clinically confirmed by.
I wonder
was not-
the salbutamol alone may not be the treatment of either
Yes, sir, but
either COPD or bronchial asthma. So based on something they might have done. So probably she has not been adequately treated even for breathlessness.
Your
And,
point is well taken, sir. I think clinically, probably it
uh,
goes with the asthma. Like you suggested, probably at this age, we have to think of COPD as well because of the underlying lung disease. There's some cardiac involvement as well, sir. So all those
Right,
things
right.
come together.
Right.
So
Right,
I
Sanjay.
totally agree
Thank
that,
you.
sir, the treatment for even if we consider diagnosis of asthma or COPD for this patient at that point was inadequate. But probably I think the districts were focusing more on the TB component rather than the
Right.
other component.
Right. And another point, Sanjeev, struck to me was she said that she had a severe gastric problem after, and the drug also included rifampicin and moxifloxacin. So how they have inferred that it was the moxifloxacin, which is not rifampicin, which has caused severe gastric.
So that with stoppage, I mean, with the trial of
Stoppage,
that,
I
we
think,
could stop
I
and find
think,
that it is
I
really
think,
with
I
that. Yeah.
think I did it in trial and stoppage, and they found that it was due to
Oh,
moxifloxacin.
oxymox. Yes.
Okay. Okay, go ahead.
Dr. Rajiv Tandon, questions from you? Doctor?
Yes.
Dr.
I just want to ask the presenter whether the patients, as the first slide itself, the first line mentions that there is atopy to dust. Atopy is that you have a documented raised serum IgE level. Was that the fact in this case? And number two, whether any workup for ABPA was done in this patient, as this might have been a predisposing condition for getting NTM infection.
I think, sir, I can answer that question. I think the atopy was part of the history. That is on exposure to dust. She was having rhinitis and symptoms. So that is based on that point on atopy was made. In fact, I don't think that the patient was worked up for ABPA because throughout she was going as positive, smear positive and all that. So the focus throughout was on the management of TB, VAR, NTM. So when we saw the patient only to design the regime for NTM. So from our side also, since the patient came with all features of NTM, we went ahead with that. Probably once that is resolved, I would agree with Rajendra Prasad sir and you that we will have to work up the patient for the, maybe do a spirometry and do other tests to find out whether other diagnosis should also be considered. Thank you for that suggestion.
Sir, can I speak, sir? I'm Dr. Neena.
Yeah, Neena was a treating physician at the local level. Yeah, please.
Sir, this patient is actually on inhaled steroids and formoterol budesonide combination. She was taking it from initially, and the ABPA workup was also done initially. That was also negative, sir.
Okay, so Dr. Tandon from district side, they are telling you that the patient was on ICS LABA and they also worked for ABPA. From our side, that history was not very clear because patient came to nodal center only for design of regime for NT.
Thank you.
Thank you, Dr. Rajiv. Dr. Divan sir, you wanted to ask the question?
Can I put my viewpoint? Hello?
Yes, sir, we can hear you.
Hello?
Sir, we can hear you.
Yes. I was seeing the serial X-rays that we it was localized right lobe in the beginning. At that time, surgery was not considered. Now it's of course bilateral with the right lung gone. Because NTM and which is not responding is also an indication where it could have helped. That's a point I wish to make. Over.
A valid point, sir. I think we'll go through the local experts, state experts' views also, and then we'll come back to that discussion.
Thank you.
Neeta, madam, can we go with the local expert and then maybe we can discuss further?
Yes, sir. Yes, sir. Dr. Neena, and then I think Dr. Dinu Gandhal has joined us.
Yeah. Dinu, would you like me to project the slides again if you're having issues in projecting from your side?
Yes, sir.
Okay, I'll project from there.
Good afternoon, respected senior faculties gathered here. Thank you, Dr. Srilakshmi, for presenting the case so well.
Is the slide visible in in full screen mode?
Yes, sir. Yes, sir.
Thank you.
So, next slide, please. Coming to the summary of the case, our patient is a 55-year-old female. She had undergone 2 courses of ETT, 2 with the DSTB regimen and 1 course with an NTM regimen. As per program guidelines, all the patients should undergo a NAT as a part of universal drug susceptibility test. Whenever the patient smear positive for AFB and NAT MTB not detected, we should also send a sample for NTM to the IRL. In this particular case, on 2 such occasions, when the smear AFB is positive and NAT MTB not detected, but the sample could not send for the NTM. Probable reasons are we had a longer run of COVID than at that time, and most of our laboratory services were redirected for the COVID diagnosis. That may be the reason for the not sending the sample. For an ideal evaluation of an NTM, when a smear is positive and NAT MTB not detected, should send for an NTM culture. If the culture is showing NTM, the 2 most important things are identify the species and determine the resistant pattern as per species identified. Coming to the management, all the cases of NTM isolated do not need a treatment. Treatment is initiated mainly on the characteristic symptoms if the patient has. And there should be a microbiological confirmation. If the sputum is sending, 2 samples should be positive. If BAL or biopsy specimen, 1 sample is enough. And patient should have the radiological features like a nodular lesions, bronchiectasis, or a cavitation. In this case, on retrospective analysis, we could have NTM, identify the NTM earlier. In the initial NTM regimen, and the DST regimen could not be obtained, maybe due to the non-availability of an NTM kit at that time. And the patient, on retrospective analysis of the CT, the patient had cavities. We could have started her on more intensive regimen, including amikacin. And the current result shows the species is Mycobacterium avium intracellular, and it is resistant to macrolides. The patient symptoms is persisting, and there is a radiological progression also. As Srilakshmi showed, the entire right side and left side also getting involved. So, designing the treatment regimen in mild cases, we should include the macrolide for a MAC regimen. We should include the macrolide, rifampicin, and ethambutol, either intermittent or daily. For an extensive regimen or a previously treated cases, we should give amikacin, macrolide, rifampicin, and ethambutol. This case is an extensive disease, and it is a retreatment case also. And here there is an added issue. It is resistant to macrolide, and we need replacement for the macrolide. And the possible drugs for replacing the macrolides are clofazimine, moxifloxacin, maybe linezolid, maybe bedaquiline, but there is no clear-cut recommendation due to the lack of evidence. I suggesting the expert committee decision for this scenario. And our decision is to start amikacin, rifampicin, ethambutol, clofazimine, and moxifloxacin. Our logic is, as it is macrolide resistant and it is an extensive disease, and the patient had taken rifampicin and ethambutol in 3 different regimens, so we need more effective drugs. And a nodal DRTB committee decision is to start amikacin, rifampicin, ethambutol, clofazimine, and moxifloxacin. We have done an appropriate treatment evaluation and all the clearance like a cardiology clearance and nephro and ENT clearance obtained, and the patients and family counsel regarding the course of the disease and treatment. And initially, we treated as an inpatient and later referred to the district. Surgery, we got a CTVS opinion. They opinion that they will take up for the surgery after 6 months when smear negative. And patient is not a proper surgical candidate and bilateral extensive disease also in this case. But the patient had severe gastritis during the IP phase, and when we started the moxifloxacin, and the patient could not even tolerate the moxifloxacin, so we currently withheld the moxifloxacin. Thank you. Seeking the opinion from the esteemed senior experts here in this case. Thank you all.
Thank you, Dr. Dinu. Thanks a lot for such an informative PPT. Are there any questions to Dr. Dinu? So now I invite Dr. Rajendra Prasad sir, who is the national expert for the day, for his comments.
Thank you, Neeta. I think the case, what the state expert Dinu has already discussed, that there has been certain delay in diagnosis, especially as program says that if the smear is positive and gene expert or TrueNAT is negative, so you initially think of a NTM, and NTM culture should have been done to begin with. And however, it was done and it shows intracellular, which is I think is the most common NTM in India. MAC type is most common. And the treatment prescribed initially was, because initially the disease was localized to the right lower zone, I say right lower low, whatever you'd like to say. So 3 drug was started, that looks right, but ultimately what we could find that patient is not responding to these drugs. So the very rightly, I believe the DR nodal committee at Trivandrum, I believe, they have advised the regimen consisting of amikacin, rifampicin, ethambutol, clofazimine, and moxifloxacin. And currently, as it is clear, she is not tolerating moxifloxacin, which is very rare. So anyhow, and now she is on a 4 drug. And as Dr. Devan has posed a very right question that if this surgery, if you suspect NTM to begin with, and disease is localized, the surgery is one of the very important option for such type of patients. I agree with Dr. Devan, but now I think when disease is bilateral, disease has extended to the left side also, as I see the X-ray and CT scan. So I think this is still I believe this treatment ran for about a month time. So I still believe that she must be continued with this for some more time and follow this lady very, very vigorously. And then treatment can be decided. We might have to add few more drugs. Also, like we have stopped moxifloxacin, we should think of adding one more drug from our kitty, and that how she may respond. But 1 or 2 points which bothered me, that usually we teach and we say that NTM is mostly on the comorbid, especially the pre-existing lung condition. So to my understanding, she suffered from some pre-existing lung condition, maybe asthma, maybe COPD. We are not clear at this stage. And as someone has raised a question of ABPA, so the presentation doesn't look like an ABPA, and the other person has also said they have looked for it. So now diagnosis looks obvious. It is, and it looks like an NTM, but my only suggestion is culture has to be repeated and then has to be followed up. That's all what I have to say.
Thank you so much, sir. So there's a question in the chat box. I think I'll take it. Why there was delayed diagnosis of NTM, and also Dr. Rajshekharan is asking that now that we are doing upfront NAT for everybody, so should we be going for smear microscopy for in such a case if we are thinking of NTM? Dr. Dinu or Dr. Sanjeev can take the question.
I totally agree, madam. So the district where we work, Trivandrum, we have already moved to 100% upfront NAT. So any patient coming today to Trivandrum gets only a NAT done. So a patient like this today, because the smear is no longer done, we will not pick up the NTM. We will pick up only if the TB is there. So probably what would happen in such a scenario is that we will do a NAT for the patient seeing the X-ray lesion. The NAT would come negative. So then we are stuck without a diagnosis, and we will work the patient further based on clinical diagnosis. In such scenario, whenever we do a bronchoscopy, we definitely will send directly for a sample to the IRL, and at the IRL they will do a smear, they will do a culture and all that. Trivandrum IRL, particularly our STO and the IRL microbiologist Dr. Chitra have been proactive in looking for NTM. They have managed to get NTM speciation kits and the sensitivity kits. So IRL is providing good service, but this FOB and everything is possible only in a medical college. I mean, if the patient is coming to a primary health center and all, this will not happen. So there is always the possibility that in the primary health center they will do a NAT, and the NAT show MTM not detected. The smear facility is no longer there at that level.
So my question is that for current treatment of NTM, have you enrolled this patient on Nikshay, and are we giving them medicines from our program, or is he buying it?
In Kerala, madam, the STO has been proactive in supporting us. So MAC is okay because the medicines are readily available. When we make a diagnosis of, say, abscesses and all that, the medicines are extremely costly and often not available. So at upfront itself, the STO's policy has been that the cases would be presented in the state difficult to treat clinic. We will make a regime, and the state will first ensure that the entire course of treatment is available for the patient. And based on that, the regime is started. All drugs are provided by the state. So the STO has been proactively involved in that. So patients do not have to buy. Our problem comes when patient goes to the private sector, and then, patient is started on a regime which may not be acceptable to the program. And then they come to us for drugs. At that time, we do get stuck.
Thank you, Dr. Sanjeev. We are also joined by our DDG madam, Dr. Urvashi ma'am. Ma'am, a very warm welcome, and we always look forward to your comments in our clinic. So over to Dr. Urvashi ma'am for her comments on this case.
Good afternoon, Dr. Anita. Good afternoon to everyone, all our senior experts who have joined us online, and Dr. Singla sir, and Director NITRD, who is leading the institute and the efforts by the institute. So I just wanted to add a few angles to a wonderful discussion case that was presented well. I'm not sure, I have been in and out of the meeting, so I may have missed it, but have the IDSA guidelines been referred to here today? Infectious Disease Society of America, that is the same as the American Thoracic Society guidelines. ATS guidelines, which were, so did we discuss that, Dr. Neeta? Since I
No, ma'am, they were not discussed.
So the ATS first set out the guidelines for non-tubercular mycobacteria in 2007, and 2020 there was guidelines for pulmonary disease. So I would urge everyone to go through those guidelines. Now, since in our country we have more TB, hence often the non-tubercular mycobacteria are a neglected or seldom studied topic. So since the people who work in this field and have spent a lot of years actually experiencing when patients relapse, it's not always MDR TB, which is the misnomer often in the field. People think that a relapse is got to be an MDR TB and start treating on those lines, and do not try to find any other pathogen. And we in the program have been actually ascertaining and encouraging that long-term follow-up of patients is very important. Relapses, the earlier we catch them, the better, we can help the patient. And post-TB lung disease is one ailment which we actually need to spread the word around, that we need to strengthen our program teams to find it early. And I concur with Dr. Rajendra Prasad sir when he says delay in diagnosis, and the others who have raised this. Delay in diagnosis is something that in the new program strategy has no place. So for TB also, we don't want any delays in diagnosis. For post-TB lung disease, it is imperative that all of us put our forces together, and teach continuing medical education to not only look for non-tubercular mycobacteria, but also aspergillus, or even post-TB fibrosis leading to, compromised. So basically, the NTM also come in because of the fibrosis. They are clearly known to form, what is the right name? So they will be resident flora, just like any other, non-pathogenic flora. But then once there is fibrosis, they will form membranes and could lead to disease. There'll be proliferation and it would eventually lead to disease. There are, some evidences also that TB and non-tubercular mycobacteria could coexist, which again will be difficult to prove because whether it is culture, whether it is NAT, they all have a limit of detection below which these tests will not be able to detect the presence of non-tubercular mycobacteria. Whether a co-infection of TB and non-tubercular mycobacteria, whether we can actually ascribe the disease to one of them is another difficult question. Nevertheless, when it is not TB, for example, the gene expert in this case was negative, while the non-tubercular mycobacteria grew. Here we should take into account the American Thoracic Society guidelines, which actually talk about clinical, radiological, and microbiological criteria. If we want to talk of microbiological criteria, we have to have at least 2 cultures from non-invasively collected samples if it is sputum, invasively collected sample if it is a BAL or a biopsy. Even a single sample culture positive will be good enough. Now, having said all this, I would briefly allude to the treatment. Of course, all the experts have dealt with. So I agree with Dr. Divan that if it is a contained lesion and a surgical excision is the best option, which is also recommended in non-tubercular mycobacterial infections of the other organs, non-mycobacterial disease. And to Dr. Prasad sir's point that avium is the predominant, that is the global data. Avium seems to be the predominant. But of late, in the past few years, Mycobacterium abscessus, which is again a very sturdy species, seems to be overtaking in studies from abroad, in studies here. We are finding a lot of abscesses. When we talk of the right regimen, again, it was briefed beautifully. But yes, we have certain new molecules which could be useful. Why did we think of MOXY to begin with? We could have looked at levo. That quinolones can be. We can start with maybe 1 generation less. Or why not look at things like injectable penims, imipenem, and the group. And possibly, of course, linezolid was mentioned. The message is that we have to have a combination of more than 4 to 5 drugs and a prolonged treatment, 12 months culture-free. Culture-free meaning on treatment, the patient should be culture-free for 12 months continually. That is when you can stop the treatment. Again, a follow-up post-treatment is very, very important because these patients can have a recurrence. It's a biofilm they are forming inside the lung, in the cavities which are fibrosed. The drug levels to be optimally reaching where the mycobacteria is a tricky business. So you can well imagine a fibrosed cavity with biofilms of mycobacteria which are leading to disease. And again, I have mentioned that there could be coexisting co-pathogens as well. So it's a complicated illness we're trying to deal with, and we must give it all our knowledge put together and a well-defined regimen, care that the patient is culture-free for 12 months. Again, post-treatment follow-up is the key to a long life for this patient. We've published several papers around non-tubercular mycobacteria, lung disease, compromised longevity, and so on. But the experiences today in this forum have made this discussion more fruitful. And I would say, in fact, I've been actually in the program strategy also, I've been repeatedly saying all abnormal X-rays should be taken, should be considered as disease. and we should not depend on a X-ray AI tool telling us if the X-ray is TB. All abnormal X-rays we must work up, we must confirm with NAT whether it is TB, and if there's a suspicion of non-tubercular mycobacterial disease, we must also do the way Dr. Nair's team has done. There has to be a suspicion first before you can actually reach a diagnosis and offer the right treatment. So I think that in a nutshell were my suggestions and observations. Possibly the ITSA guidelines, the ATS guidelines will be something that everybody could read. For the 2020 guidelines is a wonderful document for pulmonary non-tubercular mycobacteria. So thank you, Dr. Neeta.
अरे ये भारती मैडम का रूम खोलो ना, मैं अंदर ही हूँ.
Thank you very much, ma'am, for your precious guidance. And I think you brought out very important points about long-term follow-up of the patients, and we should keep the possibility of NTM in mind if there are any post-treatment lung diseases. So thank you, ma'am. Are there any questions on the chat? Yes, ma'am. So Dr. Dinu and your team, we have some questions on the chat.
Yeah, even Dr. Urvashi ma'am have also pointed out in this patient we could have started with imipenem and all also. So the question in the chat box is, the patient has already taken rifampicin, ethambutol and azithromycin for the past 1 year. So the sensitivity pattern I am not aware of, it was not very clearly visible. So we are again giving rifampicin, ethambutol along with amikacin and clofazimine, as moxifloxacin has already been performed. So isn't it a weak regimen we should have been studying further? Dr. Sanjeev sir, maybe you can answer it.
I'll take it. Yeah. So basically, the question is well taken, but the point here is that if you go by the guidelines, what Madam was just mentioning, Madam DDG was mentioning, if you go by those guidelines, it is very clear that for rifampicin and ethambutol, and the lab sensitivity and the clinical response do not match. So we don't really know the patient has definitely got rifampicin and ethambutol for a long time. Now, the lab results showed that macrolide is resistant. So we cannot use a macrolide now. So that is already done. Amikacin or injectables, it is sensitive. So we are using an injectable. So that point is well taken. I mean, ideally the NTM regime would be, the MAC regime would be amikacin, rifampicin, ethambutol, and maybe one added drug would have been enough. But in this particular case, like it was mentioned, patient has got repeated courses of rifampicin and ethambutol in the past. So we were not certain whether those two drugs would actually count for a strong enough regime. That is why we added 2 more drugs. So in fact, there are 3 new drugs in the regime. So amikacin is a new drug, moxifloxacin was a new drug, and clofazimine was a new drug. So actually 3 new drugs. The other 2 drugs, rifampicin and ethambutol, we cannot actually do a sensitivity and determine whether it can be used or not. So we decided to continue those 2 drugs, which the patient was anyway tolerating well. I hope I have answered the question.
Thank you, sir. Thank you. Thank you, Dr. Sinji. Are there any questions? Any comments or questions?
Sanjeev, in some of the papers, they say when there's when you find less number of drug, even isoniazid could be useful in MAC conditions. What?
Yes, sir. Totally agree, sir. Because I think even
Urvashi has said that in newer guidelines they're also saying, so that could be another drug which could be think of. But in this case, I think now there is a one totally destroyed lung probably on the right side, and even half of the lung has also been involved in the left side. Now it becomes a very difficult case. So we have to be very careful while following up. And I agree with Dr. Urvashi that as we see in tuberculosis, it is more good in NTM infections. The post treatment follow up should be very rigorous. So my suggestion that this patient has to be followed up very rigorously and has accordingly. Now surgery currently I don't think is in the focus. It should be in the focus because disease is now bilateral. And probably if I see the shadows on the left side, they appears to be very new shadow.
New shadows, yes.
So disease has definitely progressed. There's no issue. Because from the right side you cannot see anything, but on the left side it looks like a new shadow. So let us hope.
Yes.
Still, I think we have only 1 month of treatment with this modified regimen.
Not yet 1 month, sir. Less than 1 month.
Not yet 1 month. Let us hope for the best, but needs to be a very rigorous follow-up about this patient.
Thank you, sir. Your points are very well taken. And I think we have the advantage in Kerala that our districts are very strong. So Pathanamthitta district, where the patient belongs, Dr. Nina was there, and she was the one who spoke earlier. So all the workup, including ABPA workup, everything was done. So at the district level, definitely patient will get good care. It's only our job is to give them guidance on the good regime. So once we tell them on the regime, I think, and the lab is also very strong. So follow-up cultures also will be done in time, like you suggested. The patient's BMI is low, so general condition is also not that good. So I think that also needs to be strengthened through other supportive care.
Sir, I have one question from you, Dr. Sanjeev, sir. So what is your take on use of bedaquiline in such cases? So there are no such documentation we have few case reports which are reported not from our country, from outside countries, which have shown fairly good response to bedaquiline in NTM case. What is your take on that?
Madam, like Rajendra Prasad sir said, we like the ATS guidelines and the new ATS IDSA ERS guidelines do not really give any clear instruction on what to do once you have macrolide guide. Then all the other things what we read are all case reports and individual experience case series from various parts of the world. So like you rightly pointed out, we have also read, bedaquiline being used in such cases. So Madam DDG was also pointing out that maybe some of the newer drugs can be used. We have been reluctant to use the drug because we are not sure whether we are permitted to use the drug and whether, because we have no experience with the drug in such conditions. But bedaquiline obviously is a safe drug. The cost to the program is there. But if we are allowed to use the drug, I think we have particular these cases now, she is not tolerating moxifloxacin. So probably if permitted, bedaquiline would be a good drug for this patient. I totally agree with
you. So there's a question, are there any guidelines on NTM for the country? Means Dr. Anita is writing it will be useful to have such guideline.
Anita is our nodal officer for Thrissur. So what I can say is from the current, Madam DDG is now revising the PMDT guidelines now once again. So I think new guidelines probably will have more sections on NTM. The previous guideline gave very broad guideline and they give you a reference that in case of anything further, you have to refer to the ATS, guidelines on NTM. So it's a cross reference which is given. So obviously, even our guidelines do not cover this fully, and we'll have to go to the ATS guideline. Madam mentioned 2 guidelines. The newer one is actually shorter. And if you want to go more in depth, you'll have to go to the older guidelines with the 2007 guidelines, which is more extensive and covers it in greater details.
So that question was from Anita Kumari Madam, not me.
Okay, I didn't realize that. Sorry. Anita Madam is part of she was our previous chairperson and she is expert in the area.
Okay, thank you, sir. Now I invite Dr. Singla for his comments.
Okay, thank you. You see, first of all, I would like to thank the team from Kerala, Dr. Shri Lakshmi, Dr. Dinu, and Dr. Sanjeev for picking up such a good case, which we normally are not discussing. Although there will be few cases like this, but they are not being discussed. So I think that's why this case was taken up so that we can spread the message. And also I'm grateful to Dr. Urvashi. We all know she has worked extensively on NTMs and she published also. And she mentioned certain things which carry a lot of relevance, not only in diagnosis, but in the management also. And now you see in this case, if you just summarize briefly, 2021, where the patient was subjected to bronchoscopy, BAL, it showed MTV 1+, CMINAT negative, and given first-line ADD for 6 months. Again in 22, sputum AFP 1+, TrueNet negative, ADD for 6 months. 23, patient was given DST treatment but failed. And clearly X-ray started deteriorating, actually deteriorating from the beginning, but 23 onwards, there was significant deterioration. And on 26th of October, BAL was done, which showed NTM. And also during all this period, patient developed right-sided extensive bronchiectasis, practically like right destroyed lung, cavity lesions, and clinically also the patient was deteriorating. Then in February 24, again the bronchoscopy was done and Ball showed the MAT this time, and they could identify the species. And patient was put on RE and azithromycin. As I think Dr. Dinu already mentioned, ideally speaking, whenever you have this extensive disease, cavity disease, ideal treatment will be REZ, if the azithromycin, with amikacin. So that might have been a little better, I can say. Next. Now on 26th of May, the sample of which the result came on 8th of August, the culture isolated back, TrueNet was negative, and the same treatment was continued from Feb 24 to 22nd of June, but failed to treatment. And even after 12 months of treatment, patient remains smear positive, culture positive. And on 3rd of August, it also showed the NTM LP, I think at NIT Chennai, that there was RRL gene mutation was identified, and the case was discussed in the state DRTB committee. And patient was put on rifampicin, ethambutol, clofazimine, amikacin, and moxifloxacin, and within a month, moxifloxacin was not tolerated because of the GI intolerance. It was stopped, and patient is continuing on RE, clofazimine, and amikacin. Next. You see, just briefly, I think we all clinician also should know about this common 3-4 genes. When there is a mutation in RRL gene, like in this case, so it indicates a high level constitutive resistance to macrolide. So in this patient, macrolide will not act. And in case the other gene, that is ERM41 gene, is there, then it is associated with inducible resistance to macrolide, which is definitely lesser than this. Then regarding the injectables, because in this case it was mentioned that the RR gene was not there. So the importance of that information is, if there is a mutation only in EIS gene, then the kanamycin is resistant, but we can give amikacin and caprimycin, provided there is no RRS gene. And if there is a RRS gene mutation, then all the injectables, that is kanamycin, amikacin, caprimycin, are resistant. So from this information, we conclude that in this case, macrolide will not have any role. Among the injectables, amikacin can still have a role because the RRS gene is not there. Next. Now, having said all that, we need to treat the patient. And in this case, as already been discussed, surgery is practically out. The whole right lung is destroyed. The left lung is not normal. There are involvement of practically half of the left lung also. So in this case, surgery is out. Normally, what we do is we start a good the treatment and accompany with surgery for having a lasting cure. As Dr. Urvashi also mentioned, these are the post-TB lung disease which are very common in our country, and these are the source where NTM can invade and they form a biofilm. So even if you give for long periods, the relapses are common because they are not able to enter the bacteria. So that's why it is said that you must give treatment for at least 1 year after culture conversion. So that is the in general recommendation for all NTMs, that you must treat at least for 1 year after culture conversion because they have a tendency to form this biofilm. And they are there in the cavities, which is very common in our country. Post-TB lung disease with cavities is very common. Now looking at the drugs, you see, we had these guidelines which Madam was alluding to, that is the ATS guidelines, and which is a base document, and after the initial 2017 guideline, which is talking about the how to diagnose, how to manage, how to the various features of these NTMs. And in the same year 20, we had the clinical practice guidelines, which are again also very important, more from the clinician point of view, that how to manage such cases. But you see, even both of these documents, they did not discuss much about cases who are resistant to macrolides. That what molecules should be considered, how best is the evidence for these molecules. But when I see in the last 2-3 years, especially 2024 and 2025, there are some now, even the systematic reviews, definitely the case reports are also there. And when I went through them, I found the drugs which have sort of, you can say, better evidence of their efficacy is like clofazimine, the minocycline, and some evidence for beta-glucan also. And they also compared in one of the articles beta-glucan versus delamanid. and they found bedaquiline had lower MIC compared to daravitin. Yes, linezolid is also mentioned in these reports, but it appears that today we have less evidence for linezolid efficacy against this macrolide resistance MAC. Next. So, keeping in mind all these things, what we have discussed so far, I feel that in this particular case, we can have a regime consisting of amikacin, minocycline, clofazimine, bedaquiline, ethambutol may or may not be added. So at least then we have the you can say the 4 new drugs, out of which clofazimine and amikacin has been taken only recently, so we may not even count it. Regarding the imipinine, what Madam has also mentioned, Dr. Urvashi, yes, it can be considered, but issue is the logistic challenge. It has a lot of logistic challenges. You see, to insert a big line, to give an IV infusion for 1 hour in the morning, 1 hour in the evening for 3, 4, 5, 6 months. It's a great, plus the cost, it is a great logistic challenge that most of the time we find it difficult to administer to the patient. Even the program may not support the imipinine. And also the evidence for imipinine is not as much in this macrolide resistance NTMs, in MAC, sorry, as I could find in for the amikacin, minocycline, and clofazimine, and some for bedaquiline. So based on these facts, I feel that in this case we may consider imica, minocycline, propa, and pedicure. You see, I think it's a time has come that regarding bedaquiline, we should not restrict only to the documented patient cases. In isolated cases, which have been discussed in the state level difficult to treat TB clinic, which have been discussed in the national difficult to treat TB clinic, and if everybody feels that we should give in these cases, I think we should be open in using this neo drugs. Rifampicin, I have not included, the reason being patient has taken enough of rifampicin and has failed to the treatment. And also, as we know, rifampicin reduces the CYP450, which will lead to lower blood levels of bedaquiline. So definitely, plus patient is used. So in this case, rifampicin I am not considered. So to conclude, I am suggesting a regime of amikacin, minocycline, clofazimine, and bedaquiline with or without it. Thank you.
Thank you, Dr. Singh. We have a question. Dr. Nina has raised her hand. Dr. Nina?
So I have a doubt. Actually, the problem with this patient was she was remaining smear positive, but all her follow-up cultures was negative. So, but she had a clinical radiological progression was there. So, can we consider it as a failure after 6 months? Because the culture was repeatedly coming as negative, we couldn't do the macular DST, we couldn't do. Initially, pre-treatment, we tried to do it NIRT, but at that time, kit was not available. So that was a problem with the patient. So if the patient is deteriorating and the clinical radiologically and the smear is persistently positive, can we consider as a failure of regimen and consider adding the injectables and other regimen? And the other question was, this patient is having severe sinus tachycardia. The rate was almost around more than 150 every time. So she's on triple drugs, on ivabradine, calcium channel blockers, and beta blockers. So bedaquiline, whether it will be almost like a heart failure with preserved EF, her clinical findings was fitting to that. So what about that, sir? That was a concern.
Okay, thank you. Both the questions are very, very relevant in treating this case. Firstly, you see, as you said, if patient is smear positive, even if culture is negative, deteriorating clinically, and you can see a marked deterioration in the X-ray also. I think we are very confident in declaring the patient as failure to treat. That this current treatment, whatever is going on, is ineffective and it will not work. And if you just continue this medicine, patient is going to deteriorate and will develop resistance to more and more. That's augmentation of resistance to more and more to these drugs. And then even if you try to add 1 or 2 drugs, that will not be effective. Regarding your tachycardia, it's a genuine question, but I don't know. You see, in this case, if tachycardia is to the tune of 150, anytime it can lead to even a V-type also. So in this case, have they considered giving antiarrhythmic drugs like amiodarone, etc.? Because the triple combination which you have given, the calcium blockers, they may not cause, they may not be effective in tachycardia. Beta blockers, yes. So I think we need to consult a cardiologist that we have to bring down the pulse rate. And after that, only we should consider giving bedaquiline once we have taken care of the tachycardia. 150 to allow a patient to live with a tachycardia of 150 in a case who is already lung functions are compromised, which will again lead to tachycardia. Plus, if the patient has tachycardia due to other reasons, we must need to treat it. And I think another opinion should be taken. And then after that, we can take a call whether to give bedaquiline or not.
I think, sir, in this case, because we were giving Clofa and Moxie, which were again cardiotoxic drugs, we had gone through the very strict cardiology evaluation, and they actually permitted us to use. So probably we'll have to go through that once again, and then the cardiologist permits under observation, we could start with that. Thank you for your very nice summary and opinions. Thank you.
Thank you, Dr. Sanjeev.
Yes, Dr. Rajiv Tandon.
I would like to just make two statements. One is that getting NTM infection itself is a risk factor for having all kind of arrhythmias, especially atrial fibrillation. And to Dr. Sanjeev, would we now like to label this patient as a non-white case of Lady Windermere syndrome based on the initial X-ray appearance of this patient?
I agree with you. The initial X-rays were quite typical. So it could have been an exam X-ray. A spotter, Rajendra Prasad sir probably would have kept it in his X-ray textbook. So the initial X-ray was very typical. But by now it's so extensive that, you cannot make any conclusion.
Are we giving bronchodilators to this patient? She was breathless in the polyclonide.
I'm sorry, I didn't understand the question.
So are we giving bronchodilators to her?
Mucolytics?
Bronchodilators, sir. She was
Bronchodilator, yeah. The patient was on salbutamol inhaler, and what Dr. Neena tells us is she was on a inhaled corticosteroid LABA as well. So one of our seniors from the state committee, actually, Dr. Sunny was asking whether ICS LABA can be a risk factor for NTM. So that was also a question in the chat box.
So this is because formoterol and even levosorbital both can cause tachycardia.
Yeah, I agree.
Yes, sir. Dr. Rajendra Prasad, sir, you were trying to say.
Actually, initial some more workup maybe that what baselines he was suffering from. Is it was really asthma, or it was because asthma usually starts from childhood. It doesn't appear at the age of 50, 55. So most probably to me it looks like in a COPD, but the history is not very forthcoming. COPD history is also very so I think the team there must work up what she has, what obstructive airway disease she has currently, because she has a multiple problem. So you cannot give very large amount of drug or very combination. So one has to be very careful in prescribing these medicine. And we have always said unless your diagnosis is very clear, we're likely to have a multi-therapy, and that may not be in this particular case, as she has sinus tachycardia and other issues. So one has to be very careful. That's all.
And Dr. Sanjeev, I must say that you have a luxury of having this mutations like RLL, EIS, ERM. So I don't know. I think NIRT Chennai is the only lab with certificate clinical samples. So I wish that we could take your reference to the NIRT to have access to these.
No, sir. I must say that our IRL now is doing it. So it's only a question of kits. So kits being available. I think Dr. Amita Joshi is doing in JJ Mumbai. So it's access to kits. Kits are a bit costly, so that is an issue. I'm sure that DDG madam, being a microbiologist, probably will support us in the, expanding the services for NTM all over the state, all over the country. I think that is a need of the proportion, as I recently referred, is less than 1% of our TB suspect. Dr. S.K. Sharma had done a study which showed that around 0.9% of presumptive TB turn out to be NTM. So the percentage is still less than 1%. But in any country, as TB gets controlled, NTM will keep increasing. So we have to plan for the future, and I think this is something that should be considered. So that can reduce the delays if we have more kits and more labs available. So your point is well taken. So when we send all the way to Chennai, obviously delays will be more, and if it is locally available, delays will reduce. Thank you for it.
I totally agree with Sanjeev and Rupak Singla.
Yes, sir.
And since madam is also, I hope she is sitting or she is not sitting, Urvashi. And then the facility, even what Sanjeev said in SK Sharma's studies and other studies, also around 1% of the total TB population may have NTM. So even 1% in this country is a very large. So facilities for establishing a diagnosis and knowing the DST pattern about the NTMs, now in India it is very essential. One has to work on it, and the government has to probably spend more and more to give such type, because delay is also a very risky one. Like in this case, I know Kerala very well. I have been part of PAL and other things in Kerala. Kerala is a very well developed state, I must say. And we have a person like Sanjeev Nair and others there. So it is they are doing very well. But think of a whole country. If somebody gets, say, NTM in UP or in other states, it's a very difficult to diagnose and to know the sensitivity pattern more so. So probably some infrastructure. When I was in Patel test, I thought about this,
I would
and
like to address your concerns.
We have some initiative, madam. When I was in Patel test around 2014 or 15. So I think you are there, and so you are a microbiologist, and so please have some thought over it and all over the country.
Sir, I would like to also say most studies in the country have been done without even understanding the ATS guidelines. So the studies you quoted have not taken into account the ATS guidelines. What is published is the routine lab data.
Yes.
Which is incorrect. We should not quote those numbers. That is why I'm stressing. So when there's a biofilm, a single culture, so the logic is very simple. A single culture can be due to the biofilm. We have to have at least 2 cultures from a non-invasively collected sample, and from an invasively collected sample, a single sample is also good enough. When you talk of training the facility, sir, here the IRL was able to pick up, confirmation was done by our NRL, all those are our facilities. Just to also add on, this is a very simple thing. I mean, this is an essential thing. So all our IRLs are well trained, while we have also trained them, which no other country has done, in doing DST for the BPAL-M regimen. So bedaquiline, pretomanid are being done in 42 labs. So we are enabling our labs as best as we can. And let me tell you, we take pride in our labs and their efficiency. Be it our NRLs, be it our IRLs, they're doing a phenomenal job. Delays, yes, sir. Delays and the suspicion of non-tubercular mycobacteria are something we must work at. But in case of suspicion, a sample reaches an IRL with the history, they will be able to tell us it's a non-tubercular mycobacteria. The NRLs can come in, if the DST is required from NRLs, or even our IRLs are capable of doing it. When they can do BPAL-M DST, they can definitely do a DST to whichever drugs the treating physician would like them to do for. Again, the protocols for non-tubercular mycobacteria for DST are different than TB. But yes, the labs are equipped and are capable of doing it. So that is the idea of having intermediate reference laboratories in the states and 6 NRLs to support them. But thank you for your guidance, sir. If there is anything we can still add on, we will try to add on.
Thank you so much, ma'am. Are there any questions?
I think, madam, there is a question from Dr. Sunny on inhaled drugs in NTM. So I think that is very interesting. probably Singla sir or Rajendra Prasad sir can probably.
Yes, if you read the literature, everywhere it says amikacin liposomal inhalational one, but we have tried our best. It's not available in our country, and in such cases, they do recommend inhaled the amikacin, but it's not available in our country. But it is said to have a role in such cases.
Dr. Jaikishan sir, you want to ask some question?
Yes. So there are 2-3 comments. So once patient is immunocompromised, we should consider the NTM. 2, say in case of this, previously we used to do the solid cultures. And then we are identifying the rapid growers, and that Madam has said that put out the MAC is a common thing, but for Twitter and abscesses, they are the rapid growers. And with liquid culture, whether we can identify them easily or not. Then whether there is available facilities for the species level diagnosis of the NTM or not, and the sensitivity pattern. And then
Dr. Jaikishan, this is available. We can diagnose using liquid culture as well. A line probe assay gives us a quick diagnosis of non-tubercle mycobacterial species.
So of the rapid growers also, madam?
Yeah.
For the rapid growers?
Yes, yes, yes.
Okay.
Yeah.
Then in case of the post-TB lung disease, you have rightly pointed out that there can be co-infection of the NTM and the pulmonary tuberculosis with the typical mycobacterium. But at the same time, there may be co-infection with the pyogenic organisms also. So if the patient of the tuberculosis who is treated case of TB and is having NTM, and NTM can be a contaminant by while doing the bronchoscopy also, or in a tracheostomized patient also. And so in that type of the scenario, the pyogenic can be one cause for the deterioration of the symptoms and of the radiology as well. And then in case this much extensive disease is there, say the destroyed lung is there, then patient may be also having the other problems that the patient was having, the breathlessness and others. So there may be carpomanial also, there may be post-TB, emphysema, bronchiectasis. So we should be taking care of that part also. We should be taking the postal drainage also. And whether in the present case, they have gone for the echocardiography to have that right heart involvement because secondary to the lung disease or not, that should also be treated properly. That is what I have to say.
Thank you, sir. With this, we come.
Neeta, I'd just like to add. Yeah. So, Jaikishan sir, the co-infection is not so frequent. I only brought the topic in for the sake of completion. It is not very frequent. And as you rightly suggested, that it could be introduced because it's an environmental organism while doing a bronchoscopy. But the number of organisms introduced in this process may be less than what the test could detect. It is not often that we find the evidence of co-infection, but yes, it is an entity. Of course, when the disease is worsening, before labeling it as MDR-TB, we must rule out non-TB, non-tubercular mycobacteria.
So co-infection with the pyogenic organisms also.
Yeah, that of course a culture would pick. That the culture would pick. A routine culture would pick.
Done by the clinician. Yes. Thank you.
Thank you, sir. So with this, we come to the end of our clinic. And the take-home message for people in the field would be to at least keep the possibility of NTM in the mind. Do the post-treatment follow-up for the patients. And if the smear is positive for AFB and MTB is not detected on CPNAT, think of NTM and send a sample for culture. And from there on, maybe a patient may be referred to higher center for further management. So with this, I would like to thank everyone for joining us. Dr. Bharadwaj from NTF always joins our clinic, but today he has conveyed that he's not able to join. So on behalf of National Task Force and Dr. Bharadwaj, I propose a vote of thanks to everybody, especially to team from Kerala Dr. Sri Lakshmi, Dr. Dinu, Dr. Sanjeev Nair for presenting such an interesting case, Dr. Rajendra Prasad sir for joining as an expert, and Dr. Singla for being the clinic expert. So I thank everyone to all the participants for joining us. Thank you.
Thank you.
Thank you. मैडम अब मैं आऊँ तो